I've been using V.A.N for about 5 months now. I think it works really well. We've identified multiple patients just by using the V.A.N score that had large vessel strokes, which we wouldn't have picked up on an NIH stroke scale that we normally would use. One of the patients had an NIH stroke scale of 4, and I think the other one was around a 6. I can't remember the exact number, but both of them had large vessel occlusions. One had a large dominant MCA occlusion, and the other one had one on the right MCA. One we ended up using the V.A.N score, ended up taking him actually to IR and treating him with a thrombectomy, and he did great. And then the other one we just treated conservatively with IV fluids. It broke up the clot, so he didn't need to really go to endovascular, but we wouldn't have identified these patients that were having large vessel occlusions without using the V.A.N score, given that the NIH stroke scales were low.
So when Dr. Taleb first described to me the V.A.N protocol, and especially after I read the initial research, I was overwhelmed and just overcome with joy, because being able to localize a patient's symptoms to a vessel and then triage them to endovascular treatment is huge in the world of stroke.
So Stroke V.A.N, it's an incredibly easy screening tool to use, and what it does is identify large vessel occlusions. So when you have a patient who comes in and the patient is V.A.N negative, I know right there that the patient probably will respond well to IV TPA. Now if the patient is V.A.N positive, then I know I have to triage these patients a little bit differently.
It's actually quite easy to use. You really are looking for 4 main symptoms. You're looking to see if they have weakness, whether they have vision loss, whether they have neglect or aphasia.
So when V.A.N came along, and we can now, with a very simple, easy to remember tool that is valid no matter who applies it, and we're talking whether it's a physician, a nurse practitioner, a PA, a nurse, a paramedic, EMT, and ultimately my hope is folks at home. We will be able to very quickly triage these patients to the level of care that they require, and that's going to be the most effective for them.
So when you're looking at outcomes with a stroke screening tool like V.A.N, it's what separates V.A.N, I think, from some other large vessel occlusion scales that are out there, is that it's so simple to perform. And it was truly written for the first responders. That's what it was developed for. When I respond to a stroke alert and the nurse tells me the patient is V.A.N negative or V.A.N positive, it helps me to triage these patients quicker. This scale was not developed for a highly trained stroke neurologist. It truly was to help nurses, emergency room physicians, EMS, to better triage these patients so they can get the acute care that they need.
So the reason I like V.A.N as opposed to other scales that have been validated, is that one, V.A.N is very easy. It's positive or negative. It's a switch, it's on off, it's yes or no. There's no addition, there's no, trying to put the score on a scale and then look at different research. It's yes or no. The V.A.N looks at something that other scales don't look at, which is specifically the posterior circulation. So we capture strokes that would ordinarily be missed.
And it kind of streamlines your triage process to where you can kind of figure out, okay, which ones are large vessels, which ones are small lacunar strokes that, treatment can be a little bit different. We can identify which ones need thrombectomy pretty quickly using either a CT angiogram or an MR angiogram, and decide where they need to go, if they need to go to thrombectomy versus, just treating them conservatively depending on what we find.
How I'd use V.A.N as a triage tool is when that patient is V.A.N positive, I do the vessel imaging, but I also contact our neurointerventionalist to look at that CTA, to do an immediate read and see if that clot is proximal enough that we can use endovascular interventions to remove that clot and to improve outcomes. And I don't think you can really truly appreciate what a tool like V.A.N does until you're actually in one of those stroke alerts where a patient comes in with devastating signs of a stroke, and you have two treatment options to offer them, IV TPA and or a thrombectomy. So when you see a patient who comes in with severe stroke symptoms and we triage that patient to neuro-IR, they get a thrombectomy performed and they're back to an NIH stroke scale of 0, so to baseline. That is huge in terms of outcomes for that patient, and it's huge in terms of quality of life. This patient is not going to go to a nursing facility, with severely disabling deficits for the rest of their life. This patient is going to go home and have a good quality of life. So when you truly see those before and after, because of something as simple as using a screening tool that can easily be done in 60 seconds or less, if the patient doesn't have any weakness, then you're done. You move on, and you know that likely that's a small vessel occlusion and TPA is going to work well for them.
Stroke is devastating. It's, I think, an annual cost in this country of somewhere around $34 billion, which pales in comparison to the human cost. It's the 4th leading cause of death and the leading cause of adult disability in the United States. So having the ability to localize someone's stroke to a large vessel using a simple mnemonic tool and then go in endovascularly and essentially cure them of their problem. And this is the closest thing we have to stroke away that's ever been invented.